Welcome to Doctors on Call. I'm Jenna Miller. A pulmonologist is a doctor who specializes in treating lung diseases. They are responsible for preventing, diagnosing, and treating respiratory conditions. They diagnose and treat disorders of the respiratory tract such as asthma, pulmonary fibrosis, lung cancer, lung disease, COPD, emphysema, and bronchitis. They also specialize in treating sleep disorders, including sleep apnea. Pulmonologists perform specialized tests like pulmonary function tests and bronchoscopy to assess lung function. They also develop treatment plans involving medications, respiratory therapy, or procedures to improve breathing. Pulmonologists work closely with other healthcare providers to offer comprehensive care for patients with respiratory disorders. Lung cancer is the leading cause of cancer deaths in the United States. Can lung cancer be diagnosed early with new technology? We'll learn more about these topics and more with our guest, Dr. Jorge Cedano from Salina Regional Health Center.
Presentation of Doctors on Call on Smoky Hills PBS is made possible in part by an underwriting grant from
Regional Hospital, experts, neighbors, friends.
Prospectively Healthy and Wellness Clinic, where health and wellness begins. Naturopathic medicine, IV therapy, and wellness services.
Our team at Smith County Memorial Hospital is always striving to exceed expectations of our patients and guests. Your family is our family.
Dr. Jorge Cedano received his medical degree from ECESI University School of Medicine in Cali, Colombia. He completed his residency in internal medicine from Rutgers, New Jersey Medical School and his fellowship in pulmonary critical care from the University of Kansas School of Medicine. Dr. Cedano is certified in pulmonary medicine and critical care medicine from the American Internal Medicine and specializes in pulmonary critical care. He has been on staff at Salina Regional Health Center since 2024. Doctors on Call brings you information which may be useful to you when you see your own physician. Thank you so much, Dr. Cedano, for joining us today. We're so happy to have a fresh face on the set. So we're going to go ahead and get started with some of our questions while we wait for those phone calls to come in. First of all, what are some of the diseases that you diagnose and treat?
Well, first of all, thank you for having me here. Very happy to be here. I guess the bread and butter of the patients that we see in clinic are mostly asthma, COPD, or chronic obstructive pulmonary disease, and cough. That's going to be the main things that we usually see in clinic. However, we see more complicated conditions like interstitial lung disease, which is what people know mostly by pulmonary fibrosis. And we see something also called pulmonary hypertension, like you have high blood pressure in your body, things like that. You also have that blood pressure in your lungs, so we kind of monitor those things. But everything basically related to the lungs, we see them. That can include also lung cancer, pulmonary nodules, what we also know as emphysema and all these things.
Absolutely. You mentioned pulmonary hypertension. Let's talk a little bit more about that and what goes on with the patient.
Sure. So pulmonary hypertension, there is different types, different groups of pulmonary hypertension, but mainly means that the pressures in your lung are elevated for different reasons. One of the most common causes is, for example, when you're having heart problems or when you're having lung problems. So either one of those two, that's what we call group 2, group 3 pulmonary hypertension, and you can elevate the pressures there, so you can have shortness of breath. Usually you can see these when you have like your swelling in your legs, shortness of breath, and you cannot breathe, things like that. That could be symptoms of pulmonary hypertension. We see these things, for example, doing an echocardiogram, which is a picture of your lungs using an ultrasound, and you can see the pressures are elevated there, and then we move forward to what's causing the pressures to be high there.
Sure, and what kind of treatment are we talking?
So the main treatment is to find the reason why the pulmonary why is the pressures elevated, and then take care of that. So, for example, if the heart is having issues, then fix the heart, and that should fix the pulmonary hypertension. Or if the lungs are having issues, fix the lung, and that will help with the pulmonary hypertension. There is other causes, for example, sleep apnea can cause pulmonary hypertension. And there is another different groups of pulmonary hypertension, for example, autoimmune conditions, and when your body attacks your own body. Also infections, drug abuse like methamphetamines can cause increased pulmonary hypertension. So if we take care of those conditions, usually pulmonary hypertension improves. But there's specific treatments that we usually talk with patients in the clinic visit. Could be medications, could be infusions, could be inhalers.
Sure. Now, what are some of the other symptoms of pulmonary diseases that you've mentioned?
Okay, so The main thing with pulmonary diseases will be shortness of breath. Of course, if you notice that this shortness of breath that is usually progressive, so you starting feeling short of breath, doing things that you were able to do before, and now you're not able to do those things, or it's causing you more trouble to do them, you're feeling more short of breath, that's one of the first hints that there is an issue with your lungs. Now, it could be an issue with your heart, yes, but the main thing will be the lungs. Then you can start having some cough, for example. Cough is another factor that will tell you there's probably something wrong with your lungs. Could be also from your throat or mouth, things like that, but that's another symptom that can happen from the lung conditions. Now, sadly, some lung conditions like lung cancer, they don't have any symptoms at the beginning, and you can start having symptoms when it's very advanced and it's difficult to cure. But that's why it's important to follow the screenings that the doctor suggests to you, so you can find these diseases early. Now, I'll say that primary care doctors usually do a very good job finding these conditions and referring those patients to us pretty quickly. So usually when they find shortness of breath, they're pretty good finding what's causing the.
Sure, and you mentioned a referral. At what point does it take a patient, the primary care physician, to refer to you, or can they go directly to you?
Usually they can go directly to us when they have like asthma, COPD patients. I know some primary care physicians feel very comfortable managing these conditions, and they only send it to us when they become severe or like in later stages. But I will say if you have certain questions that you feel that you want to address by somebody that has more experience in this type of diseases, we have seen asthma from very early to very late, or very severe to very mild stages of pulmonary diseases. I will say that if you want to see a pulmonologist, you can ask your primary care physician. They're really good, usually referring us patients if they feel that that is necessary.
Sure. And at what person should a patient seek medical attention?
So that's a very important question in the sense that shortness of breath is usually the main symptom, or cough is usually the main symptom, and you have to understand that shortness of breath can be very limiting for somebody when they're trying to do physical things, or even just cooking or changing their clothes, things like that. So if you get to a point that you feel that there's something definitely going on, that you feel like this is something new, that is not going away, is progressing, I feel that that's the moment that you need to ask at least your primary care if this is normal, if there's anything else we can do. The majority of these times, this is going to be something simple, like if you have an infection, like a flu, or you have something like that. But then you can also find the significant, difficult, but very aggressive diseases early if you go and talk to your primary care as soon as you start having the symptoms. That usually is very helpful for us to catch these things early.
Sure. And what are some of the diagnostic tests you utilize for your patients?
So in our clinic, we can do pulmonary function test, which is basically you have to breathe into a tube. This basically measures all the lung volumes in your lungs. It can measure your pulmonary function, and we can do a lot of calculations that can point us to what's the problem, why are you having issues breathing, and based on that, we can make some decisions. Then we have imaging, so we can do X-rays, CAT scan of your chest to see if there's any issues, anatomical issues with your lungs, or things that we can see in what we call lung parenchyma, which is just the main lung. And then we have the other side, which is the procedure side. So we have bronchoscopies, we have lung biopsies, and we have lavages, so we can do cultures in your lungs. There is a wider range of procedures that we can do.
Sure. And who qualifies for lung cancer screening?
Thank you for asking me that. That's one of my passions that I have, is my lung cancer screening program. Right now, insurance covers patients between the age to 50 to 80. After 80 is kind of a discussion between the patient and you, how the patient is feeling regarding continue getting CAT scans every year. And then you have to be a smoker. Usually the recommendation is 20 pack a year, which basically means it depends on how much you smoke and for how many years. So if you smoke 1 pack a day for 20 years, you qualify. I'll say this, if you have other risk factors, family history of lung cancer, exposure to radon, especially here in Kansas, I will say that it will be important to mention those things so we can try to get those screening tools earlier in the game.
Sure, and you've mentioned this a couple of times, but what is the importance of detecting that lung cancer early?
So, as you said initially, lung cancer is the main killer in America in terms of cancer diagnosis. It's the second most common cancer in males and second most common cancer in females, but it's number one in both genders when we're talking about cancer. The importance of catching it early is significant because if you got them in stage 1 to stage 2, your survival rate at 16 months will be around 80 to 90%. However, you find them in stage 3 to stage 4, which is sadly 44% of the times we found in stage 3 to stage 4, the mortality, meaning only about 30% to 10% of people will survive in 16 months. So in terms of survival, it's imperative that we find them early.
Absolutely. And typically we think of, lung cancer being correlated with smoking, but there's also other risk factors. I mean, you even hear like the radon. Let's talk about that. Who else might be at high risk?
Yeah, so just to mention something here, smoking is attributed to cause 90% of lung cancers. The other 10% is dividing between genetics, radon, and now we're having this environmental exposure like pollution, basically. But the second most common cause of lung cancer in America, especially in areas like Kansas, will be radon. 35% of the households in Kansas actually are above the safe level for radon in their houses, and that's something that I've been trying to work a little bit more just to be sure that my patients know that they need to check those levels so they don't have that exposure. So will be radon, pollution like exposure to smoke, secondhand smoking can also be attributive, and then we have the genetics, which is if your family has family history of lung cancer, a non-smoker, that's something that we have to be careful also.
Sure, and obviously the goal is to get a person to stop smoking, I assume. If they are maybe unwilling to do so, what's your suggestion?
So quitting smoking, I'm going to say this, is not easy. It's something that sadly in the past was normal and we didn't know why it was bad. So people became very used to smoking. It was part of their lives. It's like drinking coffee. And so it's difficult to come out of those things. I will say this, every time I have a patient that smokes, I make sure they understand what's going on. I'll try to give them the tools. So we have nicotine patches, nicotine gums. There is some medications that can help you decrease that crave from smoking. But at the end of the day, it all starts with you wanting to quit smoking. And I'm going to be there helping you trying to achieve that goal, because that's going to help you not only for lung cancer, but for COPD and other lung conditions that are worse also with cigarettes.
Let's talk about the stages of lung cancer.
Sure. So there is different types of cancers. I'll say the most common one is what we call non-small cell lung cancer. Those ones is divided in 4 stages. Stage 1, stage 2, stage 3, stage 4, and those stages depend on if what size is the tumor, if there's any involvement of the lymph nodes. The lymph node is like the draining system of your body where that cancer drains into and then metastasizes to. So if there is involvement of the mediastinum lymph nodes, which is the middle of your chest, then the staging is going to be higher. And then we have the metastasis, which means that it goes to the other lung or goes to different organs that will make it stage 4. Our aim is to catch our patients in stage 1, because that's where we can actually offer curative treatments. I'm not saying that stage 2 cannot be cured, but it's a lot harder.
Sure, and we talked about what a person should do if they're not willing to quit smoking. Let's say a person does quit. What is the effect on their lungs? Can they get them back? I mean, provided that they catch it early enough.
So usually it takes about 10 to 15 years to go back to the general population risk of developing lung cancer after quitting smoking. So the earlier you stop smoking, the earlier you're going to have less risk of having lung cancer. Sadly, even if you quit smoking, you still have the risk of developing lung cancer for a few years. And you also qualify still for the lung cancer screening. So you still will need to have these CAT scans every year just to be sure you don't develop cancer in those 10 to 15 years after you quit. But at every year that passes that you already quit smoking, your risk of lung cancer will be even lower and lower and lower. So it definitely will decrease your risk of developing lung cancer and COPD if you quit smoking.
Very, very good to know. Let's talk about what a pulmonary nodule is.
So pulmonary nodules is just a spot in your lungs that is usually less than 3 centimeters. More than 3 centimeters will be called a pulmonary mass. But pulmonary nodules is very important because that's the earliest stages of lung cancer. So here in Kansas, you find a lot of pulmonary nodules that are not malignant. Actually, the majority of spots or pulmonary nodules in your lung are going to be not malignant, probably related to fungal infections, things that we just catch from the dust and things like that are very benign. They usually resolve pretty easily, don't require any treatment. But then you have the percentage is like a 25% of lung nodules that will, actually a little bit less, like 10% that will be lung cancer, and that's the ones that we need to keep an eye on and decide if we need to do a biopsy or we can monitor and things like that. So pulmonary nodules is very important that we identify them on the CAT scan so we know what we need to do in terms of follow-up.
Sure. Let's talk about ion robotic assisted bronchoscopy system. What is it?
So this is something that, in my opinion, is changing the way we approach lung cancer. I've been doing this procedure for around 2 years now. I was doing it in Kansas City, not as consistent, and I'm doing it right now because now I'm the only one doing it in Salina Regional. What it is basically minimally invasive biopsy of your lungs. We basically don't open any holes to your chest or anything like that. What we do is we get your CAT scan, we upload it to a computer. The computer creates a 3D map of your lungs. It works like a GPS, basically. You just follow the line, and it takes you to the lung nodule, so you can biopsy the lung through the inside. We go down your mouth, you'll be completely sleepy, and then we do the biopsy through the inside of the lung. We are opening any holes. It's an ambulatory procedure, and it's been working really, really good in the last 6-7 months here.
Sure. Now, would you rather prefer that over a typical biopsy?
So typical biopsies, the way we used to do biopsies before, and we still do some of the times because some of the patients qualify for those things, is CT-guided biopsies when you can do the biopsy through the outside. However, the nice thing about the ion is that the risk of complications is a lot less. So the CT-guided biopsy complication rate is about 15 to 25%. So 1 in 5, 1 in 4 patients will have a complication, while the ion has a risk of complications of less than 2%. So the majority of the patients, and since I've been doing it here in Salina, we haven't had a single patient that had to stay overnight because they had a complication for the procedure. And we have done about 72 cases. So it's a lot safer. And the other part that I like to stress is that you can also do staging. So we not only do the biopsy of the pulmonary nodules, we can also do the biopsy of the lymph nodes that I was talking about before. So we can, if we find cancer, we can stage it in the same procedure so we have answers as soon as possible.
Now, you might explain what kind of complications or risks you're talking.
So when I say less than 2%, the main risk that we have is something that we call pneumothorax or a collapsed lung. And I always explain to my patients, just imagine your lung as a balloon. You put a needle through a balloon, it can explode, right? So it's very similar to that. That's why we use this technology to be sure we're putting the needle in an area that we want to put the needle. So the risk of complication is a lot less. We haven't had this complication so far that had required any intervention. So that's one pneumothorax that we haven't had in Salina that required an intervention yet. It can happen. It's being described in the literature, so less than 2%, but there's also a risk of bleeding. The risk of bleeding is almost minimal because, again, the needle biopsies that we do, the needles are basically the width of your hair. They're really, really tiny. So the risk of bleeding is very, very small.
So who is a good candidate for the ion?
So a good candidate will be have somebody that has a pulmonary nodule in a peripheral area that is difficult to get to. And usually what I try to do patients that are not on any oxygen. However, we can do patients with oxygen. We just have to be a little bit more careful. The main thing that I have an issue when I'm doing the ion is that patients require general anesthesia. So then sometimes I need to get some clearance if they have some cardiac disease or some other conditions that will limit the general anesthesia. But besides that, the majority of patients, I would say 95% of people that come with a pulmonary nodule, they want to get an answer, are candidates for an ion.
Absolutely. Okay, good. Now, after a diagnosis is made, what are the different type of treatments that we're looking at for lung diseases? Usually
diagnosis takes about 24 to 72 hours after we do the biopsies, and I will call you, or the majority of doctors will call you with those results and with a plan. Before we offer you treatments, we have to know the staging. So sometimes you require more imaging and to see an oncologist and things like that. But for example, stage 1 cancer, if the patient is a good candidate for surgery, you can just go there, get a cardiothoracic surgeon to see you, and just cut it out, and you're cured. You just need some follow-up after that, but basically you don't have any more cancer after a surgery because you just took it out and it hasn't gone anywhere else. And that's the kind of patients I'm trying to find because those are the ones that are going to really change the survival at the end. Now, if you are stage 2, stage 3, or stage 4, and you don't only have this cancer in one area, there is different treatments like chemotherapy and radiation therapy. And there's now what we call immunotherapy. So we do molecular testing of these cancers and see what type of molecules they have that we can actually target, and we can use precise medications to kill those cancer cells. And finally, we have something called SBRT, which is a type of radiation. For example, if you have a stage 1 cancer, you're not a candidate for surgery because of cardiac conditions or something like that, then we can do a specific type of radiation that only radiates that area of the lung, and it's pretty safe. So it also is, the recurrence rate is more, but still very, you can aim for cure, basically.
Sure. And typically, what do you find are the symptoms between a stage 1 compared to, let's say, a stage 4?
The majority of stage 1 patients are going to be asymptomatic. They're going to find their pulmonary nodule by an incidental finding, like they did a CAT scan or an imaging of the abdomen for some other reason, and they find a pulmonary nodule. So sadly, that's why screening is so important, because sadly, we don't get a lot of symptoms at the beginning. Then when you start, when the tumor starts growing, or the nodule starts growing, you can have, like, for example, a dry cough. When it's growing too large, you can actually cough up some blood. But then you're going to start what we call B symptoms, so night sweats, fevers, or weight loss. That's something that we see quite a lot. People are losing weight pretty rapidly without trying to lose weight. And that's a big red flag that if I can mention the people that are seeing us today, if you start having weight loss without trying to lose any weight, that's something that you should discuss with your primary care.
Excellent. Good information. Okay, we're going to go to the phone lines. We've got a caller waiting to ask a question.
Sure.
This is Pat on the line from Russell. Hi, Pat. Go ahead with your question for Dr. Cedano.
Yes, I've had pneumonia 2 different times, and I feel like I'm a fairly healthy individual and have recovered fully both times. But is there truth to that I'm more susceptible to acquiring it again at some point?
Hi, Pat. Thank you for calling. So usually with pneumonias, it's kind of we have to have a specific type of information, because if you have a viral pneumonia, there's some susceptibility. For example, if you don't have your vaccine for influenza and things like that, you can develop these symptoms again. But if you have bacterial pneumonia and it's multiple times, then we have to start thinking about what's going on here. You're having some exposure, so for example, acid reflux that you're not controlling. Are you getting in contact with people that are sick multiple different times? Or there is an issue with your immune system. I would say that if somebody has multiple infections, like upper respiratory infections, infections in the lungs, even as a child, then we have to start looking for issues with your antibodies or other kind of immunosuppression stuff that you may have. The other thing that I will try to see is where is this pneumonia, in which part of your lung, because if you're having pneumonia in the same area of your lung, maybe you're having some anatomical problem that may cause you to have, that may be, that basically you become susceptible to have pneumonia in that area. But it's different things that it mostly depends on what type of pneumonia you had, because not all pneumonias are caused by the same bug or the same, they're not even in the same place sometimes. So it's kind of, we have to be very specific what type of bug you had, what situation happened, were you in a different place when you had it? So different areas of the country can give you susceptibilities for different types of pneumonia.
Sure, and it seems like coughs have been just rampant this past year.
Oh yeah.
When is it lasting too long, I guess? How long should a cough typically last?
So the majority of coughs related to viral infections like influenza will last, your symptoms should last about 1 week. When you start having this cough for more than 1 to 2 weeks, it can happen. It doesn't mean there is a red flag there, but it can become annoying. And then that's when you have to start thinking, okay, is there any other things that we can do to help you with the cough? When a cough past the 6 months, when you start chronic cough, that's when we start thinking about, okay, this is not related to an infection. We need to figure out what else is going on. So if you have a cough that you haven't been able to deal with for the last 6 months, I will definitely mention that there's something going on to my primary care so we can do a more in-depth workup.
Sure. And we have just a few seconds left. Let's tell our viewers what they can do to make their lungs as healthy as possible.
Well, I will say that exercise is something very important. If you have a job that you're exposed to a lot of dust or things like that, maybe using respiratory protection and make sure you're at work, they're trying to help you with that. That's very important. I cannot say how important it is to not smoke. Smoking is definitely one of the things that I would recommend 100% that you don't do. Check for radon in your house. That's something that is easy to do, and it can save your life if you just have a couple of minutes to check for that. And then just be very conscious of the symptoms that you have. If you feel that something is not right, I would just mention it, because I have a lot of patients that they say, I just knew something was wrong, and that's when we find things.
Excellent. Well, thank you so much again for joining us on Doctors on Call. We learned a lot tonight. Wonderful.
Thank you for having me.
That's Dr. Jorge Cedano from Salina. On our next Doctors on Call, we'll be visiting with those from High Plains Mental Health. You can email questions for our next program. That address is doctors@shptv.org. Thank you for joining us for Doctors on Call. I'm Jenna Miller.
Presentation of Doctors on Call on Smoky Hills PBS is made possible in part by an underwriting grant from
Russell Regional Hospital. Experts, neighbors, friends.
Prospectively Healthy and Wellness Clinic, where health and wellness begins. Naturopathic medicine, IV therapy, and wellness services.
Our team at Smith County Memorial Hospital is always striving to exceed expectations of our patients and guests. Your family is our family.